Doctors, we are live.
Hello, good afternoon and good morning, I guess, depending on the part of the world where you're connecting from. Welcome back, everyone. This is the Empower series where we have experts, both academic and clinician, physicians and other healthcare professionals discussing different aspects of venous disease, but largely with female experts in particular as well. So welcome back. This is our second session after the previous roundtable, and this will be on the topic of superficial venous disease. Before starting and introducing everyone, we shall just go through a couple of videos from Drs. Kabnik and Kanata who are supporting this initiative. Thank you.
Hello, everyone, and welcome to today's session. My name is Dr. Lola Kabnik, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled Empower Her, which was developed by Ruth Bush, Sarah Onida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us. Hello, everyone.
Buenos días, queridos amigos. Yo soy el doctor Víctor Kanata, presidente de Vein and Lymphatic University. Hoy estamos ofreciendo el inicio de un grupo de webinars que están destinados exclusivamente a la enseñanza, a la capacitación y a la diseminación de la experiencia profesional de varias personas que trabajan en el área de la flebología y de la cirugía vascular a nivel del mundo. El trabajo de la plataforma de Vein and Lymphatic University será permanentemente enseñanza, capacitación, dirigida fundamentalmente a un grupo de profesionales que necesitan conocer las actualizaciones en el área de la flebología, los nuevos tratamientos, así como los diversos nuevos equipos que estaremos mostrando en nuestras muchas actividades que tenemos a través de la Universidad de Venas y Linfáticos. Así que espero que disfruten de la sesión. Nuestras sesiones serán siempre interactivas y tendrán la posibilidad de la enseñanza y la certificación de todos los especialistas posterior a nuestros webinars. Un fuerte saludo para todos y desde la Universidad de Venas y Linfáticos les deseamos a todos un excelente webinar. Un fuerte saludo y muchas gracias.
Great. So before getting started with today's webinar, perhaps we'll go through a round of introductions. I'll start off as one of the moderators. My name is Sarah Onida. I'm one of the assistant professors at Imperial College London and also vascular surgery resident towards the end of my training with a research and clinical interest in venous disease. And my co-chair is Dr. Bush, and we have here a group of expert panelists who are Dr. Ozsvath, Ortiz, and Dr. Gutiérrez as well. So Dr. Bush, would you like to start off with introducing yourself, and then we can go through the panelists?
Sure. I'm Ruth Bush. I'm a vascular surgeon, and I'm a professor in Houston, Texas at the University of Houston. I will be monitoring the question and answer panel, so if you have any questions, please don't hesitate to type them in.
Dr. Ozsvath, would you like to start off?
Hi, I'm Kathleen Ozsvath. I'm in upstate New York. I'm a vascular surgeon. I'm chief of surgery at my hospital, and professor of surgery at Albany Medical Center. I do a lot of vein work in my practice, and I'm very pleased to be a part of this esteemed group here. So I hope everybody enjoys our program today.
Thank you. And just in order on my screen, Dr. Ortiz.
Hello, everyone, and thank you very much for the invitation, and it's an honor to be here as well. It's a nice opportunity. And I'm a doctor from Uruguay, and I get all my trainings of phlebology in the United States, and I came back to my country where I have vein center, and I had the opportunity, I'm still, I am member of a foundation, the Hackett Henwell Patterson Foundation of the Wisconsin University, with whom I perform a lot of treatments in humanitarian activities. And I am also happy, and I learned a lot from these activities, and I hope to be helpful, my experience here, to everybody. Well, thank you very much.
Thank you. And finally, Dr. Gutiérrez.
Good afternoon, everybody, and thank you very much for the opportunity to participate in a so high quality webinar with all colleagues from different areas of the world. I am also a vascular surgeon, and I am completely dedicated to the phlebology since more than 20 years. And one of my principal achieves is to represent the National Reference Center for the training for the Board of Phlebology and the European Board for Phlebology in our country, in Spain. I expect to learn and to add experience and knowledge, and altogether getting the great goal we all are expecting.
Excellent, thank you. So just for the attendees, this will be basically run around different cases that we will just discuss, but very much leave up to our expert panelists to discuss how they would normally manage these cases and perhaps some of the challenging aspects around these. So I shall proceed and hopefully be able to share my screen. Can everybody see that? Good. So the first case is of a 67-year-old lady who's got symptomatic varicose veins affecting her right leg, as you can see in the picture, mainly symptomatic with aching and a lot of itching around the veins. She has atrial fibrillation, for which she's on apixaban, so anticoagulated, and has had a previous total hip replacement and is hypertensive and on HRT. She has a known family history of varicose veins, and she's otherwise very mobile, independent, and keen to get on with her life. So, Dr. Ortiz, how would you start by assessing this patient? What sort of things would you be discussing in the history or looking for in the examination?
Okay, yes. So first of all, I think that the treatment success depends on a good diagnosis. So first of all, perform a good clinical examination, or not only of the leg, but also the abdomen and pelvic area. Ask about all the symptoms, and also to create our CEAP or VCSS scores, which is important as well from the history, and then perform an ultrasound. And I think that ultrasound is the most important part of the diagnosis, not only the superficial, but also the deep system to examination of the pelvic, the iliac vein, if it is necessary, if we find something like early recurrency of venous varicose veins, or if there is pelvic veins. So ultrasound is for me the next step. And I don't know if there is something else that you want to say about that.
There is, but not just yet. So Doctors Ozsvath and Gutiérrez, anything else to add? Would you do anything different? Would you also just proceed with ultrasound or duplex as such, or any comments?
The one comment I would make, in the United States, we have, unfortunately, sometimes a very difficult payer system, right? So documentation and photo documentation is extremely important. So this is a beautiful picture, because not only do you get an assessment of what the patient's veins look like, but also their skin. And this lady has or it's a lady, yes, has a fair amount of inflammation as well, which puts her in a sort of higher CEAP class. And again, by photo documenting it in the United States, we would include that when we go to ask the insurance to cover whatever treatment that we have proposed for her.
I agree with Paola. Is the name of my colleague?
Yes.
Paola Ortiz? Yes. After this story, we have to do a physical exploration, and with the signs to make the CEAP stage that will be completed with the echo-Doppler ultrasound diagnosis, of course. And I am completely agree about the importance of the transabdominal and transvaginal ultrasound exam in case of suspected varicose veins that come from the pelvis abdominal area, of course. And it is very important that the ultrasound study of the lower limbs should be complete with a complete exam of the deep venous system and, of course, the superficial vein system.
Indeed. And before we progress to the results of the duplex, we've obviously mentioned CEAP classification, and all of you have mentioned that, and VCSS as well. Do any of you routinely formally assess for impact on quality of life, such as with the Aberdeen Varicose Veins Questionnaire or SF36, or do you feel that that's sort of more the remit of some of the academic work that occurs when we sort of go through sort of the assessment of our venous patients? So for example, in clinic, we will ask how these sort of veins can affect patients. Normally I ask the patients how these affect them, but we don't necessarily get an ABVQ on every single patient we used to as part of sort of hospital commissioning, but that doesn't occur anymore. So what is your experience? Do you normally use formal quality of life assessment tools as a routine or not? And would you suggest that everybody has that? What are your thoughts?
We do. You know, we do definitely, to be a vein center and to be accredited here, it's important not only to do the VCSS score on the first visit, but we also do it after the procedures have been done. So it's, yes, to be a full-fledged vein center here, there are a lot of administrative type things that have to happen, and that's one of them. So the CEAP classification in VCSS is part of our medical record.
And I will also add that for insurance to cover many vein procedures in the United States, you not only have to document their CEAP classification, but also how the veins impact their quality of life, their activities of daily living, their ability to work or take care of their kids or whatever else someone does.
Great. So moving on, had a duplex ultrasound. It's got bilateral GSV in competence, and her deep venous system is absolutely fine. So what next?
Well,
Yeah.
if I say something, I would like to know to see the vein map, to see the measures, the diameter of the great saphenous vein, and if it is intrafascia or extrafascia, and also if there is some perforators, and so to have a view of everything, and then I will plan my treatment. And also another important thing from the history, if the patient had a previous treatment as well. So this can, change our plans if we find like thrombophlebitis or something like this inside of the vein of different sizes. So all this, the detail of the vein map will help me to decide which is the best treatment, if not, is thermal or non-thermal ablation, and if there is some perforators, also to know what to do with this perforator or not.
Indeed. Any other comments?
We haven't mentioned the possibility that this patient has an arterial pathology.
Mm-hmm.
Important to remark that in the anamnesis, we have to ask about symptoms or previous history of associated with the arterial pathology, and of course in the exploratory physical exam to look for the pulses, and because this is a 68-year-old and anticoagulated for a fibrillation, so we have to look for this possibility.
And in case that this patient has sort of, palpable pedal pulses and an ankle brachial pressure index of greater than 0.85, say, so that they're sort of suitable potentially for compression, would anyone consider a trial of compression? Is that something that you do or do you not? And what are your thoughts around that? Dr. Ozsvath, I saw you nodding, so perhaps do you want to start?
So again, we are unfortunately, we have the pressure from the payers, so from the insurance companies and from Medicare to follow a certain algorithm, if you will. So patients who have C2 and 3 disease absolutely must go through 3 months of compression management before we can intervene. C4, 5, and 6 disease, obviously they're allowing us to intervene sooner. So in this patient's case, again, the importance of seeing that this lady has a fair amount of inflammation would allow us certainly to intervene sooner. I think compression is important because not only is it important to control the complaints that you may have from achiness and heaviness and that kind of thing, but even for after an intervention, it's important that the patient be able to wear some kind of compression, and then also understand that just because we treat some veins, we can't treat the genetic problem, so they can have recurrence in the future. So yes, we would prescribe compression stockings on the first day that we meet them.
What class would you give?
So the minimum that we write for is 20 to 30. I really honestly can't get most of my patients to wear anything stronger than that or higher, if you will. I mean, even that's hard enough. And we work very closely with somebody who fits the patients with the proper stockings and so on, and has all kinds of little tricks to help them get their stockings on. You get a patient who's obese or who has really bad arthritis and is unable to don stockings, that becomes an issue. So we try to do everything we can to help them with whatever tricks out there to get those stockings on and off.
Yeah.
Okay, and regarding Bush question, I think that thigh high is the best. So not only knee high, but also the thigh high. Yeah.
Okay. Dr. Gutiérrez, do you use compression as a trial often, or?
Yes, we use always compression if it is possible, and if you prescribe a good stocking, an adequate stocking is the best for the patient. And this must be depending on the presence of edema or not. If you have not with class 2, if you have no edema, but if you have edema or of course trophic changes, you have to go through perhaps to sorry, I am I am saying a mistake. You have to use class 2 if you have edema, okay? And if you have a worse with trophic changes, then you have to use a more inelastic tissue. And this is the key point, the type of knitting, you know. You have to use rigid and inelastic cotton, o sea, devices to control progressive CEAP stage. And of course, we use, after the technical interventions, the compression is a key point in the control of venous disease, yes.
So that's very interesting. I mean, my experience is limited to what we do in the National Health Service in the UK. But for symptomatic varicose veins, we don't use compression, and NICE guidance advises against that unless it's somebody who can't have intervention. So for example, if someone is in their pregnancy, or somebody who will not have intervention and therefore for symptomatic relief. But we don't routinely prescribe compression stockings to patients if we intend on intervening on them. But you know, obviously there's different sort of setups and realities there, I guess, in terms of funding and you know, having a nationalized health service as opposed to sort of private. But so that's very interesting. And the case has got limited information, but in terms of say if this person were suitable, had, you know, large enough veins to have, say, 4 millimeter, 5 millimeter GSV, incompetent from the saphenofemoral junction down to about the knee level, intrafascial, what would be your preferred choice of treatment for this sort of lady? Dr. Ortiz, do you want to start?
Yeah. Okay, if we follow the guidelines, because I think that one important thing regarding treatment is to follow the guidelines. And there is different guidelines as well all around the world. There is the American Venous Forum, the American College of Phlebology, and also the European guidelines and Latin American guidelines. So, but most of them agree. The thermal ablation, I think, is 1A or 1B. So thermal ablation, if it's available, is my preferred option. But because it's 5 millimeters, it's not too big, we can use also mechanochemical ablation. And for example, in Latin America, there is a lot of countries where, so the only option is the surgery, and there is a long waiting list for the patients. And sometimes the patients, you know, it is an unmet health problem. The patient have the problem, and we can offer for also the sclerotherapy. And the sclerotherapy, the foam to the small saphenous vein, for example, is 1A level of evidence in the Latin American guidelines. So it is, there is a study that, and also in my own experience, I have treated a lot of gray saphenous vein, not too big, and small saphenous vein as well with foam, and I had a good result. So this is, so, and the guidelines agree with that is an option. Of course, if we have a laser or a radiofrequency, I think this is the best. And I prefer radiofrequency, for example, for this patient.
Dr. Ozsvath, any comments? What would you do?
I definitely use radiofrequency for the most part. And again, I do my own ultrasound at the time of the procedure, so I am able to gauge, you know, where the vein is in relationship to the skin as far as depth. The other thing is that we do offer cyanoacrylate as well. So, and it just depends on the patient, and we talk about both in the office before the procedure. More importantly, in a patient like this, I also offer concurrent phlebectomy.
Yes.
Yeah, that was going to be the next question, sort of concomitant or wait and see what happens. But no, I'd agree. I mean, we would treat this lady with radiofrequency and concomitant phlebectomies. Dr. Gutiérrez, any other comments? Would you do anything different?
We offer the same because it is a great saphenous vein in the intrafacial space. So we can use perfectly endothermal just endolaser or just radiofrequency ablation. But sometimes patients prefer less invasive treatment as sclerotherapy. And as this case, the lady has a small great saphenous vein, it can be a good technique. The thing is, perhaps you have to repeat 1 or 2 sessions, but you can get a good result. And even you can do it with anticoagulated. This is an important key point. And regarding the tributaries, we are lately doing only the treatment of the great saphenous vein by endothermal technique, and we are doing the tributaries in a second stage with sclerotherapy after 5 or 6 weeks. And this is less invasive treatment, and mostly the patient has not to quit the work and the normal activities, and this is very well appreciated.
Very interesting. And if you were to do, obviously, you know, she's got sizable varicosities, would the fact that she's anticoagulated have any impact on what you would do? I mean, we would normally still phlebectomize, and we wouldn't really stop necessarily anticoagulation unless you know it's very, very sizable phlebectomies and we think that there's going to be a significant amount of bleeding. But would you do anything different?
Yes.
I do. Sorry, I like to do phlebectomy at the same time. When if the varicose vein is big, it's too big, I like to treat in the same stage. And I never stopped the anticoagulants. So I had good result. At the beginning, I was like some concerned about bleeding, but it's not much. Maybe the bruise is a little bigger, but it's not much problem with the anticoagulation. So I do not stop the anticoagulation, and I do phlebectomy at the same time, unless the varicose vein are small or less than 6 millimeters. Maybe that's, you can speak with the patients and wait and do the procedure in 2 or 3 months if the small veins are still there. I had, for example, good results performing MOCA, so mechanochemical ablation to the great saphenous vein, and with when the varicose, the visible veins are small, the tributaries, I wait. And I had good result. I didn't need any other things to do. But for example, this case with this big varicose vein, I prefer to do the phlebectomy at the same time and not stop the anticoagulation.
For me, I find that a lot of it is patient expectation. And so we have the discussion in advance. There are patients that we have that and it's absolutely appropriate to just treat the axial reflux first and wait to see what happens. The problem with that is that patients will go home, they're like, well, but you didn't fix my vein. And they don't understand that just because you fix the axial veins and you didn't do the tributaries, that they just may have to come back for a secondary treatment. A lot of our patients expect, they want their legs to look, you know, like they've been completely treated. I also have a lot of patients that come from, you know, hours away that drive to have me treat them. They really don't want to come back for a whole bunch of other treatments. You know, they'll come back for follow-up, but they're not, that, you know, they really to have to drive a long distance and so on makes it difficult for them. The other thing is, again, patient exploitation. If you treat the axial reflux in a patient like this, you will get some thrombophlebitis if you don't get rid of some of the tributaries at the same time. And then you've got the patient calling and crying and, you know, now I have an infection. No, you don't. You know, it's superficial phlebitis, it's expected. So again, it's from a patient expectation standpoint, when they're this big, and just do both at the same time. As far as the anticoagulation, you know, if somebody has AFib to stop their Paxaban a day or two early is what we do when we're going to be doing a phlebectomy with this kind of venous hypertension, and then we just start it as soon as they leave. We have an outpatient center where patients basically come to our office. So the last thing I need is for somebody to go, to bleed a lot and then have to deal with that from like an accreditation standpoint. It's considered a complication if they bleed and so on. So we really do try to make it as safe and clean as possible for them. As far as treating patients with ablation who are anticoagulated, we do it all the time. But if I'm doing a phlebectomy, I usually do stop it if it's, if I can.
Yeah.
If we do phlebectomy, also we stop the oral anticoagulation and go to a heparin.
Mm.
We are trying to not to do phlebectomy because of the lymphocells, our neuropathy and hematoma. So we are changing to not to do the phlebectomy and going to sclerotherapy in a second stage by now. We are trying to do that.
Dr. Bush, did you have any questions on the chat or any questions you wanted to ask?
So one question from the Q&A is why for the doctors that do radio frequency as opposed to laser, why do you do that? Is it because of the reimbursement or just a technique that you prefer? Aren't they equal in terms of outcomes? And then the second question is, so RFA versus laser. And then for Dr. Ozsvath, you mentioned cyanoacrylate. With someone who, such as this picture, who is thin, and it doesn't look like, it looks like their veins are very superficial, have you had a lot of inflammatory response?
So when I first started doing veins in the outpatient setting 20 something years ago, I used laser and I thought it was great. And then at that time, the radio frequency catheter was different. And so when they changed, and I wasn't thrilled with it at that time because the closure rates were better with laser then. When the closure fast catheter came out, I switched. And what I found was, after doing literally a couple of thousand veins, that patients who were treated with radio frequency had less inflammation, less complaints after the procedure, and a lower risk of neuropathic issues with radio frequency. So, and I treated several of my employees, and I had employees where I did one leg with the laser and the other leg with the radio frequency, and everybody seemed to do, from a symptomatic standpoint afterwards, better with radio frequency, and I switched, and I haven't turned back. And I think it's just because it was a lower heat level. I don't know, but patients do great with that. As far as cyanoacrylate, we do offer it. We're very careful in making sure that we ask about any adhesive allergies, because in the very beginning of using cyanoacrylate, we really didn't know that whole issue with hypersensitivity. And when I had my first patient with hypersensitivity reaction, I had never seen it before. And so I got on the phone, called around with some of my colleagues like Kathy Gibson. I called her first. And I said, what do I do with this? And then, very shortly thereafter, protocols started getting made up of, how you treat it and whatnot. So now we have a protocol, and I haven't really had any issues with hypersensitivity reactions since then, but we screen our patients for that for sure. I find that a lot of patients, when they hear that they're going to get something that is considered, at least in the United States, as an implant. So in other words, it's a glue that stays with you. Some patients or many patients will say, we don't want that. We're just going to go with the, we prefer the thermal. So, of course, we treat a lot less people with cyanide acrylate than we do with thermal ablation now. But it is definitely a good option, especially, you know, in somebody who's thin, or if you're going to be using it on a patient who has an extrafascial vein.
And I guess if there's concerns about hypersensitivity with cyanide acrylate, and maybe you do have an extrafascial vein, would you go for mechanochemical as another option in terms of non-thermal?
Yes, I have. I use it very infrequently because, you know, again, I think that if you use the tumescent in the right way, it's not an issue usually. And yeah, so I really haven't had any, I've never had a thermal injury that I know of. And, you know, very early in when I first started, and I think it was a learning curve thing, and with using laser, I did have a few people who would get that discoloration, but most of the time it went away. I don't have anybody that I know of where it was permanent. So when you see that, it makes you kind of wonder, should we be doing it or not? But I really haven't had an issue. I think for me, it was a learning curve issue in the beginning. You use enough tumescent, you can push this vein way down, even in a thin patient.
Great. Any more comments before we move on to the next case, or any more questions?
In our hospital in Cruz Roja hospital in Madrid, Spain, we started in 2012 with radiofrequency ablation because we thought it was easier, because it was more standardized technique comparing with endolaser. But since 3 years ago, we started also with radial endolaser, and we like to use both techniques to get skills in both techniques. We think this is important, and perhaps the endolaser has the capability to give you more handmade work. You know, you can decide when to high or when to low the power of the energy, and perhaps it's more for a more experienced surgeon, perhaps. But you can modify more than the radiofrequency technique, I think, and perhaps even for bigger saphenous veins, you can get a more closed vein than with the radiofrequency, because the energy is more powerful. And so we like to have both techniques in the right moment. And we use the Clarivein and the Flebogrif, especially for small saphenous veins and for recurrent varicose veins. And then we use sclerotherapy for the inguinal neovascularization and for pelvic veins. And we combine with MOCA in these small saphenous veins. And the thing is to get with all the techniques, and so indicate the different techniques mixed for different patients, different veins. So I think it's the best is to get a skill in all of them.
I agree with that. Absolutely.
Yes, it's good to have knowledge of every technique and to have each patient is different, and you know, everything will depend on the patient, the size of the vein, and also our skill with the technique. For example, I like the MOCA as the no-terminal tumescent because maybe I have more experience as well with this technique other than with the glue. And of course, the glue, we have to be careful about the hypersensitivity and the history of the patient. Now there is different glue. This is something, you know, everything is changing. So maybe in the future we will have another glue, even with less granulomas, you know, as side effects. And so, but to have knowledge of each technique and be comfortable with one technique and perform this technique to our patient is one important thing to take in consideration.
One thing I would add, when I'm treating patients with ulcers, those are the patients that I find that are the most complicated when it comes to their venous anatomy, and sometimes very difficult to use tumescent or whatever under the ulcer bed. So in those patients, I definitely think combination using sclerotherapy really makes a difference. Also with perforators, what I find is that the laser, if you're going to treat a perforator, the laser that fits through the little 18 gauge needle is a heck of a lot easier than the radio frequency stylet. In fact, the radio frequency stylet, I pretty much abandoned because it's just very cumbersome. The other thing that over time that I sort of learned was that we treat the ulcer beds, what's important is yes, it's the perforator, but it's the venous plexus, that's the subulcer plexus that's important. So I find that combination with sclerotherapy makes all the difference in the world.
Yes.
Yeah, we would do the same. You treat the axial vein and then you'd get a little butterfly into that subulcer plexus and just foam everything underneath, and that travels really nicely, and that does really help with their healing as well, doesn't it? So yeah.
Yes.
And what about compression post-op? What sort of regime would you normally use? Say if you use an endothermal technique, let's just say.
Compression.
Yeah.
How long for? Day or night?
We do 48 hours straight, and then after that, just they take their shower. And they wear it daily until they come see us in office. For ablations, we see them at 1 week to make sure that everything looks good and that that they haven't had clot propagation. But that's a whole other topic.
Yeah.
So then after that, we tell the patients they probably should wear their compression, but we don't tell them that they absolutely have to. With that said, with cyanoacrylate, they don't have to wear any compression once you're done. So that's a definite plus in the summertime, when it's hot.
Yeah, I find it always quite confusing because you work for different people and they do something slightly different. So I've worked places where you do 48 hours of compression bandaging and then a week, and that's it, of class 2 compression stockings, just days. And then now we're doing compression bandaging 48 hours, day and night stockings for a week, day stockings for a further week. So it's 2 weeks in total. And I always find it very confusing as to what people do and why. That's a whole other topic in terms of the lack of evidence and things. Dr. Ortiz and Dr. Gutierrez, do you do anything different with regards to compression post-op?
I do the same as Kathleen. We put the patient on stocking for 48 hours straight, day and night, and then at least 1 week or two. And I advise my patient to use the stocking as much as they can, also after treatment. And also another detail is that a patient needs more than one treatment. So maybe the big treatment is the first day, but then next month, in a month or maybe 3 months, we have to do something else, like sclerotherapy to another tributary. So speaking with the patient is very important, as Kathleen said, expectations, pictures, a lot of things that we have to take in consideration the first day. First day is very important and have time to explain to the patient everything about the expectation, not only the treatment that we will have or will offer now, but how it will be get better and better, but maybe need more one treatment and the stocking. So we have to have a good rapport with patient as well to have a good result at the end of the treatment. And this is not also maybe one every year to come back and check the patient as well. So this is something important, I think, that we have to say to the patients.
Absolutely. And do you all follow up your patients in terms of duplex ultrasound?
Yes, I like to follow up 1 week after. I know that there is some, techniques say that maybe it's not necessary to do it, but I like to do it 1 week ultrasound to rule out deep venous thrombosis. And I never had any thrombosis. That is a good thing, that I keep doing the same, just following up the patient 1 week after with the ultrasound. And then, in 3 months or 6 months, if there is a recanalization, I like to follow the patient and see what's happening with the ultrasound. Sometimes I find some recanalization, but nothing, no complaints or no symptoms, and just, I leave this maybe recanalization, but I like to follow up the patient 1 week and then in 3 months and in a year.
Dr. Ozsvath, you do that as well?
Yeah, we do. And what I find with vein patients is that the way I think of it is that they need new stockings anyway. So if I see them after their procedure, we've done the initial follow-ups, I like to see them once a year. And I have patients I've been seeing now for 20 years that come back. And I always tell people that I can't treat the underlying genetic issue. You're going to get recurrence at some point, and if they begin to hurt or cause problems, it's easier to treat, a localized area than it is an entire leg like this. And I explain it to them kind of like weeding a garden. You weed the whole garden, but if you can keep on top of it and make sure that things stay in check, it's a lot easier that way on the patient than it is, to let it go and not see them back for 10 years and suddenly they come back with really horrible recurrences. So, and I think part of it is also nice just to keep that rapport with the patients. So we do see them back.
Dr. Gutiérrez, do you scan all your treated patients as well post-operatively and follow them up?
Yes, for endolaser treatment, we use 44 hours stockings, and then we recommend for 1 month. And after the treatment has resolved the problem, we recommend a class 1 stockings, mostly for people who work standby, stand up. Standing up. And in case of sclerotherapy, we follow the patients for 4 weeks to see the results and to do another session of treatment. And I am completely agree with my colleagues that we have to treat all the disease in the both legs, in the small veins, in the bigger veins, before to say bye to the patients. Because if you have some non-vein treated, you will have a recurrent varicose veins. So you have to be very thoughtfully to finish all the pathology. And we, in case of the endolaser and radiofrequency, we see the patients in 2 years, and because we wanted to know our results.
I see. Okay.
Nice comment from Linda Antonucci. She said that they recommend the term walking hour, which is completely true. I agree with her, because sometimes we have patients who works at night, so we have to say to the patient, use or wear your stocking when you are standing. Not the term walking hours is nice. I agree with Linda.
Yeah, we don't. So in the NHS, we treat patients and then they go. And unless they are being followed up as part of the trial, so they've been recruited into a clinical trial, or unless there are specific concerns with respect to an intervention that has been performed, we would normally, on the NHS, would not follow them up. So they'd have their stockings, they'd go home. We would tell them that it might take some time for things to get better, that they'll be bruised for a number of weeks, that they might not get symptomatic relief for a bit. And if they still have ongoing concerns, then they would be referred back from their primary care physician to come back to us. But yes, I think it's just, different setup in terms of work. It's just very interesting to see how things are done differently. Dr. Bush, any further questions before we should probably move to the next case, I think?
Yes, while you're switching, I just want to poll the panel. There was a question about where do you put the tip of your catheter, and I think either be laser or radio frequency. I personally, and this person asked you to do flush occlusion or 1 centimeter distal. I personally am very, very conservative. And I put the tip of the catheter 2, sometimes 3 centimeters back, at least back beyond the superficial epigastric branches, because I would rather treat a recurrence in the future than have someone have a hit or some type of thrombosis. But I'll just go across as you're switching cases. Dr. Ozsvath, where do you put the tip of your catheter?
I really want to know what the anatomy is like at the saphenofemoral junction. So I want to be distal to whatever tributary, superior epigastric or whatever. Sometimes you can see the anterior accessory and the great saphenous come together very, like right together. Sometimes they're a little off of one another. I think it's important to know what the anatomy is and be distal to that first tributary so that you, in that cul-de-sac, that you don't develop an issue.
All right, Dr. Ortiz.
Yes, I agree. The same. I'm conservative with the tip position. It's like 2.5 centimeters. This is where I used to position the tip. And also, I'm sure about the epigastric vein is not occluded when I. So it's good to see how is the junction and yes, 2.5. Not one too close for me. 1 centimeters.
Yes,
And for the small saphenous vein, Linda is asking, I like to position the tip of the fiber when the vein is going down, it's at the curve in the for the small.
Me too, agree.
yes, we do the same. We put the tip of the catheter around 2 centimeters distal to the saphenous femoral junction, or in the level of the fascia in case of the small saphenous veins. And we agree that it is very important to keep patent the tributaries to prevent the neovascularization and recurrent varicose veins in the junctions. Yes, it's very important. And also we recommend to examine the competence of the saphenous femoral junction in the 1 week postoperative exam. Because you can get that the junction get competent after the thermal ablation. This is very important.
Great. If there are no more questions, should we quickly whiz through another one? Yeah. So you've got a 27-year-old female. She's got BMI of 33. She's got bilateral symptomatic varicose vein. She works as a hairdresser. She's not really coping. Bit of swelling, lots of aching, she's otherwise normally fit and well, is on the combined oral contraceptive pill. I'll jump to the duplex actually, because I think we've discussed a number of aspects in terms of assessments already. So she has got bilateral disease, truncal. So on the left-hand side, she has GSV and her SSV are both incompetent. And on the right, it's just her SSV. And she has very superficial and incompetent tributaries throughout the legs. Now, in general, does the presence of a patient with a high BMI change your approach to either treatment or to thromboprophylaxis or to approach? And if you have bilateral disease, would you consider treating both at the same time or one leg at a time? What's your sort of usual approach, I guess? Dr. Ortiz, if you would like to start.
Well, first of all, speak with the patient about the weight as well, all the habits, because the result will depend of everything. Also, if she, do some diet to help the treatment. And then I like to treat only one leg, not 2 legs at the same times, because this will increase the risk of thrombosis. Or, I like to treat one leg and maybe do the like the great saphenous vein and tributaries, but not 2 legs at the same day. And Regarding the anticoagulation, I will consider the Caprini score. And also now with the COVID, and we have to consider a lot of things in terms of anticoagulation or not, and it will depend of the Caprini score. At least this is the guideline I follow in regards to the anticoagulation or prophylaxis, during the treatment.
Dr. Gutierrez or Dr. Ozsvath, any comments?
Yes, we in our hospital indicate the surgery only if the BMI is under or equal to 30.
Oh.
We consider very important the obesity, and this can be prevented. And then the risk of thromboembolism, venous disease can be prevented. And we agree with Paola that we operate only one leg to prevent or to lower the risk of thromboembolic venous disease. And I don't remember the other question.
Any prophylaxis. So obviously this lady got BMI, she's on the combined oral contraceptive pill as well,
Yes.
and having intervention. So would you consider thromboprophylaxis or extended thromboprophylaxis for her?
Yes, we apply also the Caprini risk questionnaire, and if we indicate endo laser with tumescent anesthesia, the Caprini result will be above 5. So it is indicated prophylactic treatment with heparin during 1 week or 10 days, depending on the time to recovering the mobility. But we are now with the COVID applying 10 days and even more because of the higher risk in our country for these past months. And yes, in case of endo laser radiofrequency, in general, we apply a prophylactic with around 1 week of heparin. Yes.
Dr. Ozsvath?
So patients who are morbidly obese and don't walk, unless they have a venous ulcer, and we don't intervene, if in those patients. If they have a venous ulcer, but that might be different. And again, if they're immobile, they do get treated with anticoagulation. And if a lot of our patients are pleasantly plump, and as long as they're able to move around and go back to normal activity pretty much right away, then we don't necessarily anticoagulate them just for that. Those patients who have a history of DVT, a family history of DVT, or who are, factor 5 or have a thrombophilia, of course, those patients we definitely treat. If somebody tells me that they're, for example, coming from a distance and a long car drive, that type of thing, we will anticoagulate them just for the drive home. We will do that. But that's pretty much it. I think if somebody's mobile and they can move around and they don't have a thrombophilia, I don't know that they necessarily need to be treated. Again, history of superficial phlebitis, or even those patients we will treat.
And then just because obviously Dr. Ortiz mentioned this, this is not evidence-based at all, unfortunately, but just what are your thoughts? If somebody's having a COVID vaccine, week they're having their treatment, what would you advise? Because we've had a patient recently who came to have her veins done and then was going to have her vaccine a few days later, and she was like, "Oh, is it perfectly safe?" And then the answer is, "Well, don't know, actually. Keep mobile and keep hydrated." But so we were discussing this with some of the consultants, and none of us really quite knew, because obviously there's no evidence. But what would your thoughts be on that? I'm sorry, it's a bit of a curveball, but I'd be interested to hear.
Aspirin.
Aspirin.
Yep.
Yeah.
my daughter had COVID and she's an athlete. And I put her on aspirin the first I heard of it. And this was back in sort of the early days of COVID, but there's we all know now that, the risk of the risk of thrombosis in those patients. So we treat with aspirin in somebody who has had a recent COVID infection or who has just recently been vaccinated.
Interesting. And any thoughts, Dr. Ortiz Gutierrez? It's a bit of a strange one. But...
In case of vaccinated, we wait for 1 week after or before the vacuum.
Yes,
a recommendation of our health authorities in Spain.
All right. Okay.
Yeah. So because there is thrombosis due to COVID and some thrombosis due to vaccine, so we have to consider all these new things about this patient. And I like to treat the patient after vaccination. So I prefer to, and this was something that Caprini said in one webinar, wait until the patient is vaccinated to offer a treatment of the superficial veins. And be careful about all the risk factors. And yes, I think that aspirin for, is something that help to, I don't know if prevent, we don't know much about that. This is the reality of everything, but think about that and follow the patient closely. Now, for example, in my country, the COVID now is, everything is late in my country, so COVID is late as well. So now we have the COVID, the real infection, a lot of patients with COVID now. But at the same time, we are having a good vaccination rate. So there is a hope that next month or in 2 months, we will see the improvement. But now we have to be very careful in treating the patients because of the COVID. And it's better to have the patient vaccinated and wait like at least 1 month after the vaccine, the 2 vaccines, to treat the patients.
I have to say, this is a very appropriate conversation, and these are people, as you said, Sarah, there's no evidence, and we don't know. I think unless there is an urgent reason to treat the venous disease because of an ulcer, because of bleeding or phlebitis, I like what Dr. is saying in terms of possibly waiting or treating with aspirin.
Yeah.
I wanted to add that last year in our country that we had a high incidence of COVID. When we were better and we started to operate again patients, we consider that if the patients had a COVID disease, we had to wait for 2 months before we indicate and do the treatment for the varicose veins. And this has been supported by a study in our country that in general, we have to wait to do a surgery to patients that had COVID and around 8 weeks.
So for us, I mean, during the COVID epidemic, when it was really going on, all elective surgeries and procedures were stopped. So we didn't offer any kind of venous interventions to people. The only people that we did were ones who had active venous ulcers that were getting worse. So those patients we treated, but otherwise we really cut back a lot. So now we're seeing all these patients that have been waiting for the past year to get done. And most of them, if they've had COVID, it was a while ago. But it is definitely a question, and all our patients are pre-screened, even just to be able to step foot into the office.
Yeah, that's the same with us. So they need to have a negative COVID swab within 72 hours, and they need to have self-isolated. And if you don't have your COVID swab back, no surgery. And we've only just started maybe last month after more than a year of not doing any venous intervention. So from an NHS perspective, we just stopped and we just did arterial work, but no veins whatsoever, which obviously, you know, now we've got a large number of patients with ulceration coming through. It's had a devastating impact, hasn't it? So
Yes, we the same. We had a lot of patients with ulcers, and in the high incidence pandemic, we only treat with this kind of patients, but I prefer lately when, for instance, in my hospital, there was no any case of COVID. So we started to do ambulatory interventions and of course, venous interventions. And then we consider this issue to decide when to do the intervention in case of the patients had a COVID, to wait around 2 weeks to around two months to do the venous intervention.
One interesting thing that I would comment is that even after COVID started to die back, we saw, and this is a little bit off the track, but we saw a lot of very interesting cases in the hospitals, like the kid who comes in, you know, at the age of 18 with renal vein thrombosis, that type of thing after COVID infection. So I think that we won't know for at least another year or more how COVID really impacts patients when it comes to thrombophilia. And I do think that we're all just learning. And I think that, you know, hopefully those of you in countries who are just getting hit by it, you know, God bless. I hope you get through it fast, because it really was a rough year here.
indeed. Dr. Bush, any other questions at the moment?
There is one question that was put in about, have you all seen phlebitis in the extremities after a COVID vaccination or worsening symptoms from varicose veins after a COVID vaccination? I have not.
No.
Don't think we have. Unfortunately, they would present to their family physician, practitioner, sort of GP in the community before they came to us. But we haven't had any, I don't think we've had any increase in referrals of symptomatic thrombophlebitis in the midst of COVID.
I haven't seen thrombophlebitis. I've seen like renal vein thrombosis in an 18-year-old. I've seen that type of thing come through the hospital. You know, DVT-PE that was unrecognized, and then suddenly, you know, that's the type of stuff that we see, like, you know, deep vein problems.
We see a lot of arterial thromboses, actually.
We did too.
Yeah. Not so much on the venous side. I mean, they might be coming to the medical team, to be fair. They don't come necessarily to vascular surgery, but in vascular, we're just seeing arterial thrombosis left, right, and center.
Yeah.
Now,
with thrombosis, you know, graft thromboses,
yeah.
Mesenteric ischemia. Yeah, it's crazy.
I know.
I agree.
I think we've got 7 minutes. Do we want to quickly run through one last case, maybe ask some targeted questions? So speaking of 78-year-old ischemic heart disease, COPD, smoker, knocked his leg, non-healing ulcer. It's had compression in the community, long-standing skin changes, you know, non-healing in the community for a number of months, and then just on an aspirin, a statin, and inhalers, and eventually made it to our hospital for assessment and management. And incompetent perforator and subulcer plexus, and he also has an incompetent truncal vein. Obviously, we've discussed a bit of the aspects of sort of assessment and management, but one of the things that I find quite frustrating is that we have a very hard time in getting patients with venous leg ulceration in the community to ever present to our services. And actually, if you look at the EVER trial, a large proportion of the screened patients were excluded because they had ulcers that had been there for too long, because they've been, you know, in the community for a very long time, being told dressings are the only treatment that you can get, and that's just the way it is. So there's a lot of work going into the reasons for that. I was just wondering, in your own countries, is that something that's happening, or is it better there? Do you get more prompt assessment and management of ulcer patients? what's your experience? Dr. Gutiérrez, perhaps to start off with?
Yes, we have a lot of work in the organization, changing the organization. We have a big area that depends on our unit. It's around lower leg. Sorry?
We can hear you now, sir. I think you cut out for a second, just technical issue. So I think we just missed the last bit of what you said. If you could repeat it, please.
Yes, that we have done a lot of changes in our area of PG, and we have got that patients can be transferred to our unit, and our goal is to treat them, to eliminate the superficial venous reflux in less than 2 weeks, as the randomized clinical trial has shown. And we use a lot of sclerotherapy because the majority of these patients had as old, very old, and has a lot of trophic changes. And the sclerotherapy is basic treatment for this pathology. And of course, if we had the possibility to do an endothermal ablation of the saphenous vein, we do, of course. And even the senocrilato we use for small saphenous veins with success. And yes, this patient is the patient that needs more, and we have to focus all our knowledge and skills to get a better outcome. This is the most important patient that we have in front of us.
Absolutely. And Dr. Ortiz, briefly, I think we have 4 minutes left. Your thoughts on how quickly can you get patients in? Is it easy?
Well, I think that to treat the axial reflux is the most important step. But I had a lot of experience in Central America with Dr. Julian Javier in Dominican Republic and with the University of Wisconsin in Honduras. And we treat thousands and thousands of patients with ulcers, and you know, and they don't have enough, we don't have lasers or something like this to offer to them. So we do sclerotherapy to a lot of them with excellent results. So I think that sclerotherapy for ulcers is an important step to the to the bed of the, you know, under the bed of the ulcer. And of course, if you have all the available devices, you can treat the great saphenous vein or the small saphenous vein with the laser or mechanochemical ablation or glue, and plus the sclerotherapy under the leg, the ulcer, and compression. Now with this patient, we have to think about the arteries because, you know, a smoker, so probably has so not only vein ulcer here, maybe some multiple causes also.
Indeed. Dr. Ozsvath, any comments?
So, I mean, I always tell patients, no pun intended, but arteries trump veins. So if you have a patient who has an arterial problem that has to be treated, because then you will end up burning or killing veins that you actually may need for arterial bypass. I think the patients who are at highest risk of limb loss are patients who have combined disease. You need to treat the arterial problem first and then treat the venous, because otherwise you'll end up losing the conduit that may be needed for a bypass potentially. We always start with endovascular first, so we try to revascularize them endovascularly, and then if the arterial circulation is improved, then going after the venous disease is fine. But I think you have to be really careful.
Absolutely. And Dr. Bush, any last questions or comments in the last 2 minutes that we have left?
there was one question in the chat about doing foam sclerotherapy in the small saphenous vein, about techniques with regards to junction. I personally only do thermal ablation in the small saphenous vein, and similar to the other panelists, keep the catheter within the fascial layer because of the risk. But if anyone does foam sclero of the small saphenous, feel free to answer.
Yes, I have a lot of experience with sclerotherapy foam to the small. I do I do this 2% polydocanol foam with the Tsari technique, and I inject ultrasound guided and I compress the junction, but I never had any deep venous thrombosis doing this. And I learned this in the Dominican Republic and also in Honduras, like 8 years ago or more, and I was really concerned about injecting foam into the saphenous vein or small saphenous vein or grade. And then I realized that if we think about the risk factor the patient had, if there is no risk factor, and then it's really safe. I think this is safe, and also there is a lot of study that show it that the risks are less than 1% of the venous thrombosis. And then if you can follow out your patient, you can see if there is deep thrombosis, but I never had any.
Thank you. Well, I'm afraid it's 5:15 my time, which I think brings us to an end. So thank you. It's such a shame. It always feels like we don't have enough time because there's so many other questions and cases we could go through. But this has been really, really informative, really fantastic to hear everybody's point of view. And I'm glad the attendees got to participate as well. So thank you so much, Dr. Ozsvath, Ortiz and Gutiérrez. It's been an absolute pleasure to have you in this webinar. And I had one more case, which unfortunately we don't have time for, but this is just to let you know that next month we're going to look at deep venous disease. We'll have another group of panelists for our Q&A session. So thank you everyone, and hope to see you at the next session.
Yes, thank you panelists, and thank you Dr. Onida. Have a great rest of the weekend.
Thank you very much.
Thanks, Dr. Bush. Bye.
Thank you very much for the opportunity. Thank
Bye.
you. Have a good weekend.
And you, bye-bye.